great pleasure to introduce our next speaker, Dr. Evelyn Lockhart. She is the Associate Director of the University of New Mexico Hospital Transfusion Service in Albuquerque. She is the former Associate Director of the Transfusion Service at Duke, where she furthered her commitment to women and girls with blood disorders by relentlessly pursuing a program for massive obstetrical hemorrhage prevention right into the delivery room and into our operating rooms. We are honored to have Dr. Lockhart as a member of our board of directors of the Foundation for Women and Girls with Blood Disorders, and we are further honored to have her speak to us today on the global perspectives on obstetric hemorrhage and management. Thank you.
Thank you so much, Dr. James, for a very gracious introduction, Dr. Alving and Dr. James, as well as the Foundation for inviting me to speak on such an important topic. These are my disclosures. I would like to point out I've performed consultancy for CSL Behring regarding the use of Fibrinogen Concentrates in obstetric hemorrhage. I will be discussing that today, and I will be discussing ROTEM in passing, a platform for testing coagulation, for which I have also disclosures with the parent company TEM Systems Incorporated. I wanted to today go over some of what we understand about the epidemiology of obstetric hemorrhage, who's at risk, and how does this perhaps differ between high and low resource countries. But primarily I wanted to focus on information that is going to be helpful for you in going back to your institutions and looking at protocols for managing these fulminant and dangerous hemorrhages. The World Health Organization had estimated that 78,000 women died worldwide in 2013 as a result of obstetric hemorrhage. Interesting conversation with Dr. Kassenbaum yesterday suggested there may be some differences in data sets between groups, but I think this highlights the challenge we have of really wrapping our hands around this problem and understanding the scope. The annual global incidence had been estimated at greater than 10%, affecting nearly 14 million women, which at least 10% of them or more who survive are themselves going to be suffering severe anemia as a consequence. And in fact, severe anemia itself is a risk factor for postpartum hemorrhage, highlighting the importance of the symposium today in addressing this problem, that now this may be something that is precipitating postpartum hemorrhage. In looking at proportionately what our parturients are dying from worldwide, again, the World Health Organization had estimated over 25% of women died from bleeding in the setting of pregnancy. And unfortunately, this is a disproportionate risk. As we've highlighted today, those in low resource countries have been disproportionately affected by sickle cell anemia, malaria, and similarly, they are disproportionately affected by the incidence of postpartum hemorrhage. Estimates for Africa are as high as 1 in 40 risk of maternal death, whereas in more developed areas such as Europe, that's closer to 1 in 3,300. Part of what is so challenging for us is in the healthcare resources that these countries have. Most of these women are going to be delivering at home without skilled attendants, without nearby healthcare facilities. And in fact, it may even be impossible to get to healthcare facilities because of lack of roads or transportation. But again, the scope of this problem is difficult to understand right now because those countries that are most plagued by postpartum hemorrhage are those that have the least resources for public health, as well as touch-and-go systems for data collection. In looking at the U.S. experience, this was sampling from a national inpatient sampling of ICD-9 codes looking at postpartum hemorrhage incidence in the United States. And it was implicated in almost 3% of deliveries. And the CDC has identified that recently, from 2006 to 2009, that hemorrhage accounted for 11% of pregnancy-related death. I'd mentioned that we're, I think, more fortunate in developed countries such as the U.S. in that perhaps looking at data on maternal mortality is not going to be the best way for us to look at our systems, but rather looking at perhaps evaluating the women who have severe maternal morbidity resulting from postpartum hemorrhage. To that end, the CDC has made some recommendations, and perhaps we could touch base on those later. So what is driving postpartum hemorrhage in the United States? What we're noting, not only in the United States, but in other developed countries, Europe, Australia, is that the rate of postpartum hemorrhage appears to be on the increase. This may be due to better data collection, but in part it may be driven by increasing incidence of uterine atony. Atony, the failure of the uterus to clamp down at time of delivery, and as so nicely illustrated in our last talk, the large spiral arterioles in the uterus, unless that uterus clamps down at time of delivery, can pour a tremendous amount of blood out and can precipitate a severe hemorrhage. We know some risk factors for atony, that it may be due to older maternal age, it may be due to increased use of uterotonics for induction of labor, but unfortunately, most cases of uterine atony do not have an identifiable risk factor. The take-home point for you as a practicing hematologist or physician is that obstetric hemorrhage, life-threatening obstetric hemorrhage, can happen in any case, any patient, even a previously healthy patient. And this is a challenge. This is an image graciously loaned by Dr. James. And I feel it's important for this group to see this, because these patients, the coagulopathy that can develop during obstetric hemorrhage can be incredibly fulminant, incredibly rapid, and very difficult to treat, occurring in up to 0.5% of all parturients. On top of this is the fact that at least 500 mils per minute of the maternal blood supply is coursing through the uterus at a term delivery. 15% of her blood supply per minute. There is no time to be deciding how you're going to assess this patient, how to get your blood products to the point of care, what adjuvant therapies need to be used, what doses to use. All this needs to be planned ahead of time, and the team carefully rehearsed on how to execute this. And to this end, really, there's not a single professional obstetric organization that does not recommend and encourage use of protocols for obstetric hemorrhage. And this illustrates why these protocols are so important. With uterine atony leading the etiologies of postpartum hemorrhage, clearly the need for upfront as well as ongoing obstetric management through use of uterotonics or uterine tamponade embolization, all these clinical interventions need to be decided upon as the team is identifying the cause, as the obstetricians are seeing if there may be retained placenta, atony, a laceration, Concurrently, it should be, these patients should be assessed for whether they have developed a coagulopathy as in addition. And of course, resuscitation needs to be swift and aggressively pursuing whether this patient has a coagulopathy that needs to be addressed as well. What is not included on this is communication. And I would say for protocols, communication is one of the most challenging aspects. For those who are hematologists and who may be working as consultants for your obstetric teams in helping manage these cases, it's important to ensure that that pathway of communication is open at all times. So specifically honing in on coagulopathy, that is complicating postpartum hemorrhage, and recommendations about coagulation testing. This was a publication from earlier this year, an international panel of experts on obstetrics that had looked at what the evidence was and made recommendations. And I think these are excellent recommendations. In my experience, these patients oftentimes can have coagulation testing, unless it is protocolized, forgotten in the mix as the team is trying to administer uterotonics, as they're trying to administer these other interventions. And these recommendations are stating that at the time of postpartum hemorrhage recognition, a set of labs should be collected, and periodically, at least every 45 to 60 minutes, until the hemorrhage is controlled. There are some that have recommended testing every 30 minutes, and part of this may be gaming the system a little bit. If you request it every 30 minutes, you might get it every 45 minutes. But those groups, I would say that we had recommended that at Duke, and after a while, by gosh, we were getting it every 30 minutes like clockwork. So these tests should be assessing primary and secondary hemostasis through a platelet count, PT, PTT, and fibrinogen levels. But in addition, for those who may be familiar with point-of-care viscoelastic clot-based testing, such as thromboelastography or TEG, or perhaps the other platform, thromboelastometry or ROTEM, these can also be performed and may be helpful in giving information on increased fibrinolysis. I think for this group, it's well recognized that pregnancy is a hypercoagulable state marked by lowered protein S, reduced fibrinolysis that increases in reduction throughout the course of pregnancy, as well as increased procoagulant factors. What I wanted to draw this group's attention to is while there may be general awareness that fibrinogen levels are increased, noting how much in term pregnancy fibrinogen levels are increased compared to a non-pregnant individual, with a non-pregnant individual anywhere from 200 to 400 milligrams per deciliter, term pregnancy being 350 to 650. This may, if an obstetrician who's unaware of this draws a fibrinogen level on a bleeding term parturient and they see a fibrinogen of 203, they see it's in their normal reference range, and they say, oh, okay, this is not that bad. That would be significantly low for a term pregnancy. In fact, this has been, I think, one of the points that we can say most definitively at this point about obstetric hemorrhage is that fibrinogen appears to be a robust biomarker for severe postpartum hemorrhage. This was first noted in a seminal study by Charbet and colleagues, and this was a multi-center study in France that had looked at severe versus non-severe postpartum hemorrhage. How they defined severe were those hemorrhages where the patient received 4 or more red cell units, had a decrease in hemoglobin of greater than 4 grams per deciliter, had some intervention, procedural intervention, embolization, uterine artery ligation, hysterectomy, or death. And they compared those patients at time of hemorrhage recognition and administration of uterotonics to those who did not. At that time, they collected a series of standard coagulation screening tests, platelet count, as well as more esoteric tests like euglobulin clot lysis time and thrombin antithrombin complexes. And out of all these tests, the only one that held up in multivariate analysis as predictive of severe postpartum hemorrhage was fibrinogen. And in fact, fibrinogen less than 200 milligrams per deciliter had a 100% positive predictive value for those who are going to progress to a severe postpartum hemorrhage. These results have been seen with Klaus fibrinogen levels in other studies, and importantly, there was a study that I included the reference at the bottom of the slide here that had identified point of care tests, ROTEM. Those results also directly were predictive of severe postpartum hemorrhage if they indicated the patient was hypofibrogenemic. I wanted to, I'm uncertain about how at your particular institution, how quick your turnaround time is for fibrinogen levels. Some places are fortunate in that they will have turnaround time 30 minutes or less. I'm seeing some smiling faces, some frustrated nods of, yeah, we don't have it quite that fast. So this is what I wanted to arm you all with, is that care of the obstetric patient is a multidisciplinary endeavor, and this means getting your laboratory medicine group, your pathologists, involved in looking at what can be done. You may not need to buy a fancy point of care or near point of care testing platform like TEG or ROTEM. What can you do to optimize the tests that you have? This was a question that was asked at University of Washington, and their goal was to get a less than 20-minute turnaround time for a panel that included PT, INR, and fibrinogen. Now, prior to this, their turnaround time was, I think, kind of par for the course, anywhere from 35 to 70 minutes. And what they did were some simple adjustments to their procedure, to their quality control. They changed the centrifuge, so they had a centrifuge, and instead of taking 10 minutes to spin, would take 2 minutes to spin. They adjusted some calibration curves, and after this, they had a turnaround time of 14 minutes, plus or minus 3 minutes. That is the time frame that successful management of obstetric hemorrhage is going to require. So we've identified that low fibrinogen is a biomarker for severe postpartum hemorrhage. And that has certainly led to, I think, something that is biologically plausible, which is fibrinogen repletion in obstetric hemorrhage may help ameliorate the bleed. So what are collectively worldwide our sources of fibrinogen repletion? Some countries may only really have on their shelf plasma. This is the most dilute source of fibrinogen, but if this is all you have, this is what you're working with. In the United States, we still primarily use cryoprecipitate as a source of fibrinogen repletion. Fewer countries in Europe are using this because of concerns of infectious disease transmission. And so these countries have, for the last couple of decades, adopted purified fibrinogen concentrates. The volume between cryoprecipitate is a little bit more dilute than fibrinogen concentrates, but certainly in a fulminant hemorrhage like we're seeing with this, the volumes that are used to replete fibrinogen are going to be well tolerated. and a little bit more about fibrinogen concentrates, at least from the US perspective. These were approved in 2009 for treatment of congenital afibrinogenemia as well as congenital hypofibrinogenemia, but it is not on label for use in acquired hypofibrinogenemia, such as DIC, such as what we see in postpartum hemorrhage. But over 15 countries have approved it for use in acquired hypofibrinogenemia, including Germany, Austria, Ireland, France. These are pathogen reduced, and over this last line is regarding the risk of thrombosis. Whenever we're looking at use of adjuvant therapy in the setting of obstetrics and postpartum hemorrhage, we always have to be mindful of the risk of thrombosis. Pharmacovigilance data that had been reported from 1986 to 2008, this was over 1 million grams of fibrinogen concentrate that had been distributed over this time, over 250,000 doses, of those doses comprising about 4 grams each. This is definitely going to more than just patients with congenital afibrinogenemia. And they reported the risk of thrombosis as close to 3.5 per 100,000 doses. There were 9 cases of thrombosis reported during this period, 7 of which were in patients who had congenital afibrinogenemia. So overall impression was that the risk of thrombosis from this is relatively low and is certainly lower than what has been seen with other adjuvants that have been used in this setting, like recombinant factor 7A. Unfortunately, the level of data that we have at this point for use of fibrinogen concentrates in postpartum hemorrhage is low, quite low. There have been case series, case reports, a couple prospective observational studies, one retrospective review. One of the prospective observational studies, AHMED 2012, I wanted to point out because this was actually one of the few that had done something close to a heads-up comparison between cryoprecipitate and fibrinogen concentrates. There have been very few studies directly comparing these in any setting. And this was a before-after when Ireland had decided to switch from cryoprecipitate to fibrinogen concentrates. They looked at patients before with postpartum hemorrhage who were treated with cryo and those after who were treated with fibrinogen concentrates. And they felt that there was not much they can say about the efficacy in terms of addressing postpartum hemorrhage, but at least they felt it was as efficacious in correcting hypofibrinogenemia. And in none of these studies did they report a thromboembolic complication in these patients. Really what we're needing at this point, we have questions, first off, is treating fibrinogen, particularly fibrinogen that is below 200 in the setting of postpartum hemorrhage, does that help ameliorate postpartum hemorrhage? Is it safely tolerated in these patients? To that end, there are some pending studies, both of whom I know at least the first one has completed this year. The second should have completed recently. The first trial, the FIB-PPH trial, I would point out is looking at fibrinogen concentrates versus placebo in just recognizing postpartum hemorrhage. This is not actually basing that intervention on laboratory data. The second trial, the obstetrics bleeding study, is actually basing this intervention on targeting those patients with hypofibrinogenemia. So that study may be closer to what our decision points would be in managing these patients. Lastly, the recent guidelines that have come out from the European Society of Anesthesia, the DASH guidelines, this is German-Austrian guidelines in the UK. Generally speaking, the recommendation for fibrinogen repletion regardless of the source of fibrinogen, is going to be around 2 grams per liter, 200 milligrams per deciliter, sometimes as conservative as 1.5. But most are finding that this line in the sand that we've found with the Charbet study may be good reason to be replacing those patients at that point. The last thing I wanted to talk about is antifibrinolytics. The amount of data we have at this point in antifibrinolytics, particularly tranexamic acid in postpartum hemorrhage, is small but growing. There had been 2 randomized studies that had undergone a Cochrane review looking at prevention of postpartum hemorrhage, not treatment, but prevention of postpartum hemorrhage. And it found perhaps a modest effect, but it wasn't very compelling. I think what's also gathered attention is the CRASH-2 trial. This was a randomized study looking at TXA in trauma, very large trial, and it showed significant reduction in all-cause mortality and bleeding deaths. Now, obstetrics, unfortunately, has been compelled to borrow from trauma for quite a bit of its guidance in massive transfusion, massive hemorrhage. But there has been some more data, more recent multi-center RCT actually looking at treatment of postpartum hemorrhage with TXA. This was a French multi-center study. This was looking at vaginal deliveries where they very carefully assessed blood loss. And their intervention had been 4 grams TXA. For those of you who are familiar with TXA, you may recognize this as a large dose. This was based on high doses used in cardiac surgery at the time, followed by a 1 gram q-hour infusion. This is a part of the study I find really impressive. Additional procoagulant treatments were only allowed after an estimated blood loss of 2.5 liters. I commend the study for their intestinal fortitude in holding to that. It gives me palpitations just looking at it. And primary outcome of reduction in blood loss. So interestingly, the use of procoagulant blood products were significantly less in the TXA group. And they did find a statistically significant reduction in blood loss. What this actually translates to in the real world is probably close to 50 mLs blood loss difference between the groups. Not impressive clinically speaking, but what I thought, and I'm not sure where, oh, here's my pointer. This is the control group, and this is the tranexamic acid group. What was found in a couple of their analyses is that it seems like the larger volumes of hemorrhage were present in the control group, not the TXA group. So suggestive that perhaps there was something in that treatment that helped prevent progression to larger volume hemorrhages. Hypothesis generating, nothing could be said for certain with those data. But now the woman trial is ongoing. This is a very large randomized study enrolling over 20,000 women. And this is looking at postpartum hemorrhage, both in the setting of vaginal as well as C-section deliveries. It's nice that both of those delivery modalities are included in this. The treatment is 1 gram IV TXA with the option to have an additional treatment if the hemorrhage is unresponsive, versus placebo with a primary outcome of death. I think another important secondary endpoint looking at safety elements of this is going to be looking at thromboembolic complications. The CRASH-2 trial showed no difference in thromboembolic complications in trauma, but that's mostly male population, and it's very difficult to extrapolate that to women. So it's important. as well as looking at outcomes for thromboembolic outcomes in infant. Why the infant? Antifibrinolytics, TXA, and Amicar can be transmitted in low levels in breast milk. It's about 1/100th of what you can see in the maternal blood, but still would be nice to have this large study set confirming whether breastfeeding after receiving TXA is safe. So in looking at the guideline recommendations, this is one where, again, the World Health Organization does recommend this for refractory uterine atony as well as trauma. They did not necessarily make recommendations about dosage. Neither did the European Society of Anesthesiologists. But the DASH guidelines, the Austrian, German, Swiss guidelines recommended 2 grams IV prior to fibrinogen repletion, as well as Abdul Qadir and colleagues also recommending administration of TXA early in the hemorrhage and prior to fibrinogen repletion to help ensure clot stability. So, here we go, questions. All right, so I have confidence in you all. What is the leading cause of postpartum hemorrhage? Uterine atony. Hey, that's excellent, excellent improvement. Wonderful. Okay, which laboratory test is most predictive of severe postpartum hemorrhage? Yay! Good job, everyone. All right, well, thank you all so much for your attention. I'm happy to take any questions.
John Bernstein from Nevada. I have a couple of questions. Has anyone looked at pre-delivery fibrinogen levels, just prior, et cetera?
Yes, it's not predictive.
Not predictive.
Unfortunately, yeah.
Okay. And then looking at that tranexamic acid study, you're comparing 2 groups. Were they both kept to the 2.5 liters blood loss?
Yes, they were.
So what did they do in the meantime?
They certainly could administer red cells. They administered uterotonics. They can provide fluid resuscitation. They gave colloid resuscitation. The colloid they used was gelatin. So they were resuscitating. They just were not using procoagulant blood products for
So they were
resuscitation.
doing the exact opposite of what you would do in a trauma.
Well, we would be resuscitating with red cells. But yeah, and looking at the more balanced resuscitation, trying to avoid a dilutional coagulopathy.
Right. You're basically setting them up for a bleed. So you're comparing, you may be saving 50 cc's, but the question is
yeah. I believe that the authors, their intent was they wanted to, as precisely as possible, look at what the impact of TXA alone is. It gets really challenging when you have TXA plus, oh, now they got platelets, or now they got fibrinogen concentrates, and that may be heterogeneous. I think as much as possible, they're trying to see if TXA alone would stop this bleed at an early stage.
Are the new studies looking at it that way too?
The woman trial, I'm not familiar with any ongoing current studies that are looking at it like that. The woman trial, I think, is more broadly getting at the question of maternal mortality. The woman trial had originally had included an endpoint of hysterectomy as well, a composite endpoint, but they found that in some countries they're actually doing hysterectomy as a means of birth control. So it wasn't a good marker for maternal morbidity.
My question is regarding the use of tranexamic acid. The use of TXA in tissue injury in emergency rooms and trauma centers is slightly different. And in fact, the Canadian Association, Medical Association, has recommended to give the TXA within 3 hours of the tissue injury. Now, the mechanism of the tissue injury, physiology of bleeding, is, I think, is different from obstetric hemorrhage. In tissue injury, you have the acidosis, the hypothermia, and the coagulopathy, maybe because of the dilution in a vicious cycle. But that is not seen in obstetric hemorrhage. So what is the physiology of bleeding in obstetric hemorrhage?
Well, the couple points, a great question. Those Canadian recommendations were on that administration of TXA within 3 hours. That was based on the results from the CRASH-2 trial that showed an effect within the beneficial effects of TXA in trauma given within the first 3 hours, after which it looked like it may have been associated with an increased risk of mortality. There may be a certain amount of anti-inflammatory properties to TXA as well, and that it actually in the CRASH-2 study, it looked like there was a trend towards lower rate of thrombosis. It didn't reach statistical significance, but lower in the TXA-treated group. As for the mechanism of hemorrhage with a postpartum hemorrhage, obstetric hemorrhage, certainly uterine atony. Part of this is just mechanical, physical. There is wide open vessels, and the muscles that need to clamp off those vessels aren't doing it. But these patients very often can be complicated with a coagulopathy that is particularly consumptive. I think a great example of this is amniotic fluid embolism, where it may be that release of thromboplastin-like material, and all the products of conception are very rich in thromboplastin-like material. And perhaps exposure to that can trigger some of what we're seeing with consumption of obstetric hemorrhage. I think there's a lot we do not understand about the pathophysiology of coagulation. I see Dr. Mann raising his hand here. Perhaps he can weigh in as well.
I just had one quick question. Assuming that these trials pan out, what are the supply chain considerations for fibrinogen concentrates and TXA?
Supply, I have not heard. Are you speaking about in developed countries or developing countries? Developing countries, this is problematic. I will mention that fibrinogen concentrates, at least in the United States, is about 3 times as expensive on a gram per gram basis as cryoprecipitate. So right now for developing countries, the ones that are most plagued with postpartum hemorrhage, it does not seem like fibrinogen concentrates are going to be very financially feasible. For these countries, though, it really is focusing on those 80% of cases that are, it's sort of the Pareto principle. 80% of your results can come from 20% of your resources. And in this case, that's what we're seeing with postpartum hemorrhage. If they focus on lower cost, active management of third stage of labor, cost-effective uterotonics, trying to ensure more skilled health attendants around, these are going to be what's effective in reducing PPH deaths there.
One of the difficulties in the approach of one-size-fits-all to therapy in hemorrhage is that hemorrhage can be caused by a wide variety of coagulation, inflammatory, cellular processes. And so it's likely that the spread that one sees in these clinical trials is because you're dealing with a very heterogeneous, you may have a common patient sitting in front of you with respect to postpartum hemorrhage, but the mechanism by which that hemorrhage is occurring can be a whole variety of things, in which a clinical trial then becomes diluted basically by multiple inputs that eliminate an interpretable outcome. To toward that end, I would encourage anybody who gets involved in these trials to identify appropriate sampling and repository techniques so that there could be a retrospective analysis of what the hell is going on.
I am, Dr. Mann, so well said, and I have to actually add in with this what is different. The same group that did the CRASH-2 trial is running the woman trial. And what is different between the CRASH-2 trial and the woman trial, an important difference is that they are doing an analysis looking at coagulation measures. They're doing a sub-study to try and see if we can have a greater understanding of what is happening with coagulation, whereas CRASH-2 was just, hey, it looked like TXA might help. We don't know if they're hyperfibrinolytic or not. They're actually looking for that in the woman trial.
I'm familiar with that approach to therapy.
Yeah. Thank you so much. Thank you.